Behavioral Health 911 event. I am Melissa Silva, the Executive Director of the Louisiana Mental Health Association. Thank you for joining us today for this important conversation. We are grateful to our community partners, especially the local governing entities that have worked with us to produce this event. LAMHA also appreciates Louisiana Department of Health Office of Behavioral Health for sponsoring today's and 9 other events across the state. We also want to thank our panel for sharing their time, expertise, and their lived experience. Over the recent years, the Louisiana Mental Health Association has worked with our partners to identify critical issues in our local communities and our state. And in response, we offer these informative discussions on behavioral health that affect both our youth and adult populations. As our state continues to work to improve programs and services for those most in need, Louisiana Mental Health Association stands tall in our efforts to educate and advocate for those same individuals. Conversations like the one today are a small but a pivotal step towards breaking the stigma surrounding mental and behavioral health and seeking the help one may need. Before we start this discussion today, I would like to highlight a few of our spring events. Louisiana MHA will be bringing you our virtual public policy on March 2nd, 2023. This is to make it easier for those of you to attend across the state. Our 6th annual conference will be held on April 25th through 26th, 2023, and will feature live virtual sessions. Finally, our Behavioral Health Day at the Capitol will be held on May 4th, 2023. More information on all of the events will be forthcoming, but we ask that you save these dates on your calendars now. Today's panel has been pre-recorded so that we eliminate the risk of technical challenges. There will be a live Q&A after the presentations and the speakers will join us. Please put your questions in the chat. You can add them now, or you can wait to the live Q&A section. Following the event, you will receive evaluation. Please help us improve these events by completing that. Again, I want to thank you all for joining us today. I hope that you learned much from our panel of experts. Have a great day.
Good morning, everybody. My name is Brad Farmer. I am the Executive Director with Acadiana Area Human Services District. Thank you for being here today. We are proud to partner with the Louisiana Mental Health Association to bring this topic to you today. Unfortunately, across the country and across Louisiana and within our area, suicide is one of our leading crises that we are dealing with day in and day out, and I'm sure you are too. So hopefully today you will be able to pick up some tips, some useful information, some meaningful data techniques from the speakers that we have put together for you to hear what's going on. Again, thank you very much for joining us. If there's any information we can provide to you after this, or you need resources on an ongoing basis, please feel free to reach out to us, Acadiana Area Human Services District. Hope you enjoy the conference. Thank you very much for being here.
Hi, everyone, and thank you again for joining this important discussion. My name is Acadiana, and I'm the Advocacy and Education Manager for the Louisiana Mental Health Association. We're going to take a look at Louisiana Mental Health Association screening data. This data was made possible by Mental Health America, and it was taken during April 2022 through June 2022. During this quarter, a total of 5,035 screenings were conducted. This map shows the top 10 parishes that participants screened in. The first was East Baton Rouge Parish, followed by Orleans Parish. The third was Jefferson Parish, St. Tammany Parish, other. 6th was Lafayette Parish, 7th, Caddo Parish, 8th is Calcasieu Parish, followed by Livingston Parish, and the last was Washita Parish. Please note that screeners self-identified with their parish. Mental Health America did not determine what parish participants were in. This graph shows the top 3 diagnoses that resulted from our screenings. The top diagnoses was severe depression. The second was positive bipolar, and the final third one was severe anxiety. Again, this graph shows the top 3 diagnoses that were reported in our screenings during this quarter. The Louisiana Mental Health Association wanted to dive deeper and take a look at the demographics of our screeners. Of those who took our screenings, 61.74% identified as being white and non-Hispanic. The second highest rate was Black and or African Americans, screening at 22.96%. To the right, you will see household income. Of those who took our online screening, 28.48% reported having a household income of less than $20,000, and 51.12% reported having a household income of less than $40,000. We also wanted to take a look at what gender was taking our screenings at the highest percentage. As you can see here, women composed of 68.68% of those who took our screenings. Males were 27.26%, and those who identified as other were 4.06% of our screeners. To the right, you will see the highest age group of those who took our screenings, which were 18 through 24-year-olds. However, it's important to note that 58.63% of those who took our screenings were 24 and under. This really highlights the need of services, especially in this age population. The screening asked if our screeners had ever received any form of treatment or support for their mental health problem. Of those who took our screening, 53.90% said that they had never received any treatment for their mental health problem. It also asked if they were currently receiving treatment or support. 49.5% reported that they were currently not receiving any form of treatment for their mental health condition. On the right, you will see that 54.15% of our screeners had never been diagnosed with a mental health condition. However, it is important to note that 82.84% reported that they did have some form of health insurance. We wanted to dive deeper and identify the special populations that took our screenings. As you'll see here, students made up the highest group of special populations who partook in our screenings at 2,320. The second highest were trauma survivors at 1,252, followed by the third highest population, which were members of our LGBTQ community at 1,251. So out of our roughly over 5,000 screeners, 4,823% of them describe themselves as being a student, part of the LGBTQ community, or a trauma survivor. It's also important to take into account general health conditions when talking about mental health. We know that a lot of people who have a mental health condition also have some form of health condition. As you can see here, people who had arthritis or another form of chronic health condition were highest screeners who identified as having a health condition, followed by people who have reproductive issues like endometriosis, and our third highest were people who have diabetes. I wanted to finish our presentation by identifying one of Louisiana Mental Health Association's key signature programs, the Fisher Project. The Fisher Project is free and is at no cost to the participant. It is a comprehensive suicide follow-up and recovery support service that lasts 6 months. And during those 6 months, participants get peer-to-peer case management and screen and participants are screened for suicide risk, safety planning and means restriction, as well as transition care and warm hands-off to either treatment or their respective communities. It is a constant ongoing assessment, again, led by our peer support specialists. If you have any more questions on the Fisher Project, please email us at fisherproject@louisianamha.org or give us a call at 225-960-6800. I hope you enjoy the rest of our presentation today. Thank you so much and take care.
Hi, everyone. Thank you so much for having me here today. My name is Sherrod Crespo, and I am on the clinical team for ViaLink, one of the nonprofit contact centers which answers 988 in Louisiana. And I serve as our Director of Outreach and our Prevent Child Abuse Louisiana Department. So today I want to talk to y'all about 988, the new 3-digit dialing code for the National Suicide Prevention Lifeline, and give y'all a little more inside scoop of what is 988 and how you can best be served in your personal life or through your clients on 988, as well as kind of do some comparing and contrasting with other emergency or resource referral lines that are available in Louisiana. So we're also going to talk a little bit about 211 as well as 911, and then give you a little bit more of an inside look into how actual contact center operations work when you are dialing 988, so that everybody can have a better understanding of how they can best have access through these contact centers and dialing codes into Louisiana's continuum of care for mental health and behavioral health services. So without further ado, let's talk about 988. So 988 is the new easy to remember 3-digit dialing code for the National Suicide Prevention Lifeline. Many of you have probably heard of this number formerly as 1-800-273-TALK. That 10-digit phone number, 1-800-273-TALK, will still work and will continue to work for some time. But 988, the new 3-digit dialing code, has been active in Louisiana since July 16th of this year of 2022. And that has been very exciting. Louisiana, compared nationally, has had a very smooth rollout of 988. And that call volume to the Suicide Prevention Lifeline in our state has gone up, but in a positive way. Not necessarily that there's more high-risk calls or anything of that nature, but really demonstrating that awareness of this service in this phone line is spreading wide. So by dialing 988, you will be routed to a local contact center and connected with a live specialist who is trained in emotional support, crisis intervention, and suicide response. These contact centers, which answer 988, are all approved by the National Network of Lifeline Centers, and they are accredited to provide telephonic suicide prevention work. By dialing 988, you can also receive resource referrals to local behavioral health resources, should that be what is best going to serve you after your phone call with your continuum of care and your wellness journey. So essentially, 988, the National Suicide Prevention Lifeline, is a national number, but it is a local service. Your call is routed to your local Lifeline center based upon the area code of the phone you are dialing from. So that is how, though it is a national number, it is your local Louisiana service, because your area code, that Louisiana area code, will route you to the Louisiana centers, which answer 988. So in Louisiana, for area codes 504, 225, and 985, those calls are routed to us at ViaLink. For area codes 337 and 318, those calls are routed to the Louisiana Center for Compulsive Gambling, LACG. And the really cool thing is that ViaLink and LACG are also each other's backup centers for 988. So if in one area, if there is a really high call volume, maybe because of something going on or just happenstance and that queue is getting a little longer, those calls will be routed to the other Louisiana agency as the backup center. So we have a really high in-state answer rate for 988 within Louisiana. So I want to contrast that a little bit with 211, because we've noticed there's been a little bit of confusion between 988 and 211. These are two completely different services and organizations. 211 is also a national number, which is answered locally in Louisiana. And 211 is primarily an information and referral phone and text line. So you can either dial 211, a 3-digit dialing code, or text 898211, and you would be routed to your local 211 contact center based upon your zip code. So 988 will route based upon your area code of your phone number. 211 will route you based upon your zip code. Louisiana currently has 3 211 contact centers, and all parishes in Louisiana are covered by a 211 center, which is actually very unique nationally. Many states do not have all of their counties covered by 211, but every parish in Louisiana is covered by a 211 center. So when you connect with the 211 contact center, you're going to speak with a live specialist who is trained in providing information and referrals to Health and Human Services. So that would be things like information or a resource referral to behavioral health resources, even things like utility assistance or rental assistance, food assistance, anything within the Health and Human Services field. So 211 is really a great resource for clinicians and providers because it can help you. Rather than you having to research or look up things on your own, you can dial 211 and access their resource database. So it's very convenient and a very good one-stop shop that Louisiana has to offer. 211 is also activated by the Louisiana government in times of disaster to provide up-to-date information on disaster activation and resources. So things like, are there evacuations? Are there road closures? Where are the sandbags? You can dial 211 when we're activated for natural disasters and things of that nature. We've also been activated for things like COVID-19 and monkeypox. 211 is a great resource for that up-to-date factual information. For some parishes, there is an option on 211 to select prompt 3 to be routed to a 211 crisis line, but that is not a universal option. 211 is primarily an information and referral line. So you want to remember 211 for information and referral and 988 for if you're in need of that emotional support component, crisis intervention, or suicide response. So all these compared to 911, probably the most well-known of the 3-digit dialing codes. 911 is an emergency phone line for when you or somebody else is in physical danger. When you dial 911, you will be connected to a local dispatch center based upon your current location. So 988 is routed based upon your area code, 211 routed based upon your zip code, and 911 based upon your current location. When you connect with a 911 dispatcher, they are going to send out any combination of EMS, the fire department, and or the police, depending on the needs of the caller. 911 cannot provide behavioral health support or local information or resources. That is not what they're able to respond to at their 911 dispatch centers. When you dial 911, unless you are able to clarify that it was an accident or this isn't the service you need, emergency services are going to be sent out to you. So be sure you are utilizing 911 when there is a physical emergency occurring. So now that we've talked about these 3-digit dialing codes and we've established that 988 is this national line, but a local service, let's talk about what actually happens at these contact centers, which answer 988 in Louisiana. So I'm going to talk to y'all about what goes on kind of behind the scenes at our contact center at ViaLink when we're answering 988. So the ViaLink Contact Center, our specialists are extensively trained for over 200 hours before they are actively answering the phone lines. The contact center training that we provide is evidence-based and it is developed and maintained by our in-house licensed clinicians. The really great thing about our training being constantly developed by our own clinicians within our agencies is that our training policies and procedures are constantly updated to meet best practices and adhere to the latest information and techniques. Our call techniques and procedures are consistently and constantly monitored for continued quality improvement, whether it's because maybe they're not being implemented correctly, or we're seeing maybe this procedure isn't as effective as we would like. We can do the research to find alternatives. ViaLink's contact center is accredited by AAS, the American Association of Suicidology, and we are also accredited by AIRS, the Alliance of Information and Referral Systems. So within ViaLink's contact center, we do answer both 988 and 211 because of this dual accreditation that we do have. So a little bit more on this training. Our contact center specialists are extensively trained in the foundational skills of providing emotional support, utilizing skills such as active listening and nonviolent communication, very well proven to telephonically be great skills for de-escalation and just providing emotional support. They're trained in crisis intervention and de-escalation, suicide response and risk assessment. We have very very strict emergency room diversion procedures, ensuring that we are never unnecessarily sending somebody to the emergency room, even if they do have a suicide risk component. They are also trained in violence risk assessment and duty to warn, and they are all mandated reporters. The training process consists of live lecture, some at-home learning and assignments, a lot of practice, skills quizzes and assessments, demonstration, live monitoring of our current specialists on the phone line, final role plays, and a final exam. A trainee will not be permitted onto the lines until the clinical trainer approves that they are ready. And their first shifts are also going to be live monitored by an experienced specialist to make sure that they are adhering to policies and procedures and just to help them out if they get stuck. As can be very understandable, it is a little bit of a nerve-wracking position. So we are constantly trying to insulate with support, especially for our newcomers onto the lines. Oops, excuse me. So the learning is not done after training. Specialists are continuously monitored throughout the year and receive extensive feedback from our supervisory staff. Our specialists also receive supplemental trainings on topics such as intimate partner violence, human trafficking, behavioral health issues, substance use, and cultural topics. Quarterly, we also hold all staff meetings to refresh on topics or policies and procedures and answer any questions that the specialists may have. We also provide in that installation of support within the contact center, a rotation of on-call supervisors. So this would be the contact center supervisory staff. We all take shifts of 24 hours, 7 a.m. to 7 a.m., in which when it is our 24-hour shift, we are available through the entire 24-hour period for all of our specialists for whatever they need. So our on-call supervisor team consists of 4 licensed mental health professionals, 3 program coordinators, and a quality assurance coordinator. The on-call supervisors are available for things even just like shift concerns, reminding somebody how much break time they have, contact center needs, like if somebody's running late for a shift or if they're ill. We're also there for clinical consultation for things such as, do we need to get emergency services involved? Is this a mandated reporting situation? If they need that kind of more supervisory decision-making or clinical consultation, we are available. And we're also there for debrief. Should they have a really rough call, they need that confidential space to talk about it and get it off their chest, we're there for that, to help them feel prepared and emotionally ready for the next call that comes in. So the goal, when you are calling these crisis lines, the goal of the crisis line is to provide a really uniquely safe space for individuals who need some support. It's a really difficult decision, as we all know and have been at some point in our life, to reach out for help and admit that you're struggling. It can, even if you have the best support system in the world, sometimes you're afraid to let everything out in front of somebody that cares about you because you don't want them to worry, you don't want them to judge you, whatever it may be. Crisis lines provide an anonymous and confidential space to talk and ask for support, really let all the gunk out. And our goal is for callers to maintain an internal locus of control. We're trying to provide a space for callers to let out what's affecting them. And because these lines are available 24 hours a day, 7 days a week, users can call in whenever they may feel they're at a breaking point or feeling overwhelmed, or they just know, I need to talk to somebody. There's no worry of upkeeping appointment times or anything of that nature. So our goal is to hear the caller, to truly listen to their whole story. There's no time limit. Provide a safe space and let them talk and validate and identify those emotions that they're experiencing. As part of this progress into becoming overwhelmed, our self-care has fallen and we're not able to process what emotions we're feeling with. Our goal is to help someone internalize and realize the emotions they're struggling with, and then provide a plan to cope with those emotions and de-escalate and return neocortical functioning. We are going to establish any presence of suicide ideation. You do not have to be having active thoughts of suicide to use any of these lines, but we will usually ask, and if you say no, we'll just move on and tell you thank you. If applicable, we will assess for safety risks, and then we're going to collaboratively establish a short-term plan for coping and safety if applicable. You've heard me mention that we practice really strict emergency room diversion, and I know there have been some social media posts or rumors going around that, like, if you call 988, they're going to immediately send an ambulance out to you. I cannot speak for policies and procedures in other states, but I can tell you that in Louisiana, that is not our policy or procedure. We adhere to emergency room diversion. We want you to talk about the stress you're feeling, including whatever degree of suicide ideation or contemplation of ending your own life that may be. And our goal is going to be to help you be able to feel rest, to be able to feel coping, and to be able to keep yourself safe. The only time in which we would involuntarily, so without the caller's permission, dispatch some sort of emergency services in relation to suicide would be because the caller has already attempted suicide that day, or because they have an active plan for attempting suicide, meaning that they know with what and when. That when time frame is within around 12 to 24 hours, and we will still try and de-escalate and come up with a safety plan. If inevitably a safety plan cannot be established, that caller is intent and imminent risk going to attempt suicide that day, I stress, that would be when our hands are tied and we would have to get emergency services involved. But outside of those, truly, we are there to let the caller be able to get out their emotions, their whole story, and help them figure out the best way for them to cope. We do offer follow-up calls to check in on our callers sometime within the next 24 hours. And if applicable, referrals can also be offered during this follow-up call. It's really important for callers to be able to be de-escalated and have some time for coping for the day or evening to establish that return to neocortical functioning after being in a crisis state before they actually receive referrals if they are needed. So we do try and either make sure that we give those referrals during the follow-up call, or that if we did give a resource referral the previous day, that we check in and make sure they still have the information and know how to access that resource. So access to crisis lines provide 24/7 support, which encourage and maintain internal control and well-being, and can also provide an access point to the continuum of care. But truly, they're there for whatever. You just had a stressful day. Sometimes it's easier to talk to a stranger. Don't keep those emotions in. There's always someone there who cares and is willing to listen. Nothing is too big or too small to give us a call. So with that, I thank you so much for your time, and I'll be here in the panel if anybody has any questions.
Hi, everyone. My name is Dr. Raymond Tucker. I'm an associate professor of psychology at Louisiana State University, and I am excited to talk to you all about how suicide risk prediction is a 50-50 chance. We're not very good at it, and it's basically a coin flip. But you know what? That might not actually mean all that much for preventing suicide in our community. What we know from our existing data is somewhere between 45 and 46,000 people die by suicide each given year. That's about half the attendance of a packed game on a Saturday night at Tiger Stadium. And it equates to a suicide rate of about 14 out of every 100,000 people dying by suicide in the US each year. And that's one suicide every 12 minutes. When we take a look at the leading causes of death, suicide in 2020 was a 12th leading cause of death. It's usually the 10th leading cause of death, but you saw COVID increase and jump in there that year as well. It sits around the 10th leading cause of death each year. When we look at youth ages 15 to 24, suicide is the third leading cause of death in our country. Unfortunately, what we've seen is a stark increase in suicide. Since 1999, the United States has seen just under a 30% increase in the suicide rate, with some states, like those in the Mountain West, experiencing rate increases of almost 60%. Here in Louisiana, we have seen an increase in suicide that mirrors that of the national average. Again, right in between 25 and 30% since 1999. Now, 45,000 lives lost to suicide each year is a lot, but that's actually the smallest number we consider when we think of the impact of suicide across the globe, but particularly here in the United States. When we expand this out, I like to call suicide like a funnel, with the most narrow end is who dies. But if we look at our best available data from the CDC, it estimates that about 3.5 million adults alone will plan their own suicide in a given year, with over 12 million adults having suicidal thoughts in a given year. Thoughts of suicide like, I want to kill myself, I should kill myself. So although 45,000 is a fairly small number, and that's a lot of lives and loved ones impacted, when we broaden that funnel back out, we can see millions and millions of people each year struggling with suicidal thinking. And we need to be considering that in our prevention approaches. And so if I were there with you today, I would ask, well, why? Why suicide? Why do people die by suicide? This may be the most foundational question in suicide prevention. And when I ask communities this answer or this question, I often get answers that you'll kind of see from mass media. Things like depression. I think of one of the more impactful suicides in the media that we've ever really experienced. When you looked at how the media portrayed Robin Williams' death, depression was constantly attributed to that suicide. Similarly, Chester Bennington from Lincoln Park. You will see, conversations on Twitter from Chester's now ex-spouse or from a widow, that this is what depression looks like. You'll hear things like depression as maybe one of the major contributors to suicide. And let's go take a look at not even just depression, but how about mental health problems? I think the prevailing way we think of suicide is caused by poor mental health. Let's take a look at that. Well, between 60 to 90% of those who die by suicide have a mental health disorder at the time of their death. Depending on the research study, depending on the methodology used, that could be upwards of 90% of people. So the vast majority of people who die by suicide are experiencing a mental health disorder at the time of their death. Well, let's go ahead and flip that coin. Less than 3% of those who have a mental health disorder die by suicide. And in fact, in our work with Our Lady of the Lake Regional Medical Center here in Baton Rouge, we ask people who have attempted suicide or are experiencing active suicidal thoughts. We do really very deep risk interviews with these individuals. And we ask them, what makes suicide an option for you in the future? Or what made it possible for you 3 days ago? Very rarely do we hear mental health problems. We hear different concerns. So mental health symptoms, based on our existing research and some of our clinical work in the community, are absolutely part of the picture. But if the only way we see suicide prevention is through changing mental health systems and procedures, or having more mental health care providers out in the community, we're only getting at part of the puzzle piece. And this idea, I hope, maybe is even reflected more when we just look at the role depression plays in suicide. At most, our attributable risk studies think that depression could be accountable for, or at least a major part of, about 50% of the suicides in the United States in a given year. But each year, the CDC estimates there are 14 million episodes of major depressive disorder. But yet again, only 45,000 deaths by suicide. So again, when we flip that coin, although depression probably is at play for the vast majority of people who kill themselves, the vast majority of people who have depression don't think, plan, or attempt suicide. So yet again, when we flip that coin and we look at it the opposite way, we start to recognize that depression may be at play, but of course is not the end all be all of understanding suicide prevention. So it's highly related to suicidal thoughts, but not strongly related to suicide attempts or those who die by suicide. And this is where our psychological theories of suicide try to extend past mental health problems. That there are things that we can experience in our psychology day to day that are maybe related to mental health problems like depression, anxiety, or post-traumatic stress disorder, but additionally, people can experience these without having mental health problems. And so I'm going to speak to one of these theories, because there's definitely dozens of them. They're all competing to see which one's more accurate and which one predicts suicide better in the future. But I want to just show you one as an example of how we're starting to understand suicide, not just in the understanding of mental health disorders. So simply looking at the mental health symptoms related to suicide doesn't seem to be extending our understanding and prevention of suicide. And so theories like the interpersonal theory of suicide, created by Dr. Thomas Joyner out at Florida State University, tries to explain this. And this theory has some data to support that when somebody feels thwarted in their belonging, this is inherently an interpersonal understanding of suicide. Thwarted belongingness is a belief that one is alone and that no one cares about that individual. And there's an element of non-reciprocal caring too, that others don't care about me the same way I care about them. So here you can see that someone's belongingness is thwarted or it's stopped. Someone feels alone and like they're going to be, and no one cares about them. However, not everyone who feels lonely kills themselves. So similarly, the theory believes that perceived burdensomeness, or a belief that others in someone's life would actually be better off if the person killed themselves or were dead, that needs to be occurred. And those two together is where serious thoughts of suicide are likely to develop. Again, can depression or anxiety make someone feel more lonely or like they burden other people? Of course. But somebody can feel like they're a burden to other people after a surgery or after losing another individual and experiencing grief, or losing a job, not necessarily related to mental health itself. I do want to point out one thing about perceived burdensomeness and where Dr. Joyner really kind of came up with this concept, or the reason why it was put into this theory, is one way we've kind of understood the psychology of those who have attempted to die by suicide is reading suicide notes and coding them for themes. If we have, and in fact, this exists, there are hundreds of suicide notes in the Library of Congress, where there's a repository of suicide notes that people can donate, loved ones can donate to advance science and suicide prevention. And when we code suicide notes, one of the major themes that come up is this idea of self-liability. People are apologizing to other people. They're saying things like, you'll be better off. I'm sorry what I've done to you. I'm sorry that I've made things so bad. And so the two things that we really see the most in those suicide notes are immense psychological pain. I couldn't go on. Life is too hard. But also, I'm sorry, and you'll be better off without me. And so often when I hear this sort of stigmatization around suicide being a selfish act, which is oftentimes how people who are left behind after suicide sees someone else's killing themselves, when we actually go into the notes, the people who kill themselves actually think it's almost altruistic. They're doing somebody a favor, even though that's not actually true. So this is what Dr. Joyner's theory posits, that it's these two things in tandem that suicidal thoughts likely emerge. But again, 12 million Americans think about suicide each year, 45,000 die. These two things can't be it. And that's where this third circle comes in. Dr. Joyner used to call this capability for suicide. It's sort of morphed over time to capacity for suicide. That when suicidal thoughts are on board, someone has the capacity to act on them. Capacity being that they're not afraid of death. Someone who's extremely fearful of death, they're less likely to act on their suicidal thinking. And someone who has a higher pain tolerance. Again, if they can stomach the idea of a painful suicide attempt, they're more likely to act on suicidal thoughts than somebody who can't. And again, what I want you to note is things like depression, anxiety, and PTSD are often loosely, if not minimally or not at all, related to somebody's pain tolerance or fear of death. It could be very related to their thoughts of suicide, thwarted belongings, these things, but often less correlated to this. So it's when all of these three things come together is the perfect storm, where lethal suicidal behavior is more possible. So hopefully you can see where a theory like this extends beyond just mental health concerns and is helping advance our understanding of suicide prevention efforts. And so I wanted to give you some background on what suicide is, its prevalence in the United States, and a little bit about how we're advancing our knowledge about why people die by suicide. But the how of suicide prevention certainly is worth a discussion as well. And I would argue that the thing that has maybe gotten the most scientific research, grant dollars, funding, and certainly just general interest from my field of psychology is suicide prediction and suicide risk assessment, basically identifying those who are likely to go on to attempt or die by suicide. So factors that we have looked at, as a young clinical psychologist in my PhD training program in the early to mid 2000s, I was told that things like depression symptoms, suicidal thoughts, planning or preparing for a suicide attempt or practicing a suicide attempt, or a history of past suicide attempts. I needed to assess for all of these things to better understand and predict the likelihood that my current patient is going to kill themselves in the future. So let's go take a look at what our research says about how well the gold standard factors that we need to consider are actually predictive of suicidal behavior. And I can tell you, it is never good when the American Psychological Association releases a press release like, after decades of research, science is no better able to predict suicidal behaviors. So this came out at the end of 2016. Another amazing researcher out of Florida State, Joseph Franklin, did the first ever, they call it meta-analysis, where you take all of the previous studies on one research question. So this research question is, how well can we predict future suicidal behavior, regardless of what we're predicting it with: depression, suicidal thoughts, age, gender, firearm ownership, any of these things, doesn't matter. How well can we actually do it? And instead of running this study with 10 million Americans and spending billions of dollars, you can collapse data that's previously been studied by taking the data from previous investigations and sort of bringing them together and reanalyzing. That's why it's called meta-analysis. And so I'm going to read an excerpt from the interview that Dr. Franklin did with the American Psychological Association about what he found in this "Can We Predict Suicide" analysis. He was quoted to say, "Our analyses showed that science could only predict future suicidal thoughts and behaviors about as well as random guessing. In other words, a suicide expert who conducted an in-depth assessment of risk factors would predict a patient's future suicidal thoughts and behaviors with the same degree of accuracy as someone with no knowledge of the patient who predicted based on a coin flip," said Dr. Joe Franklin. This was extremely humbling. After decades of research, science had produced no meaningful advances in suicide prediction. And this has been extended to even major questions like, how well do suicidal thoughts predict eventual suicidal behavior? This is another one of those meta-analysis on that very specific question. And I'll read a part of the abstract from that study. It says, "The main finding is limited sensitivity of suicidal thoughts for predicting eventual suicide, such that approximately 60% of people who go on to die by suicide have not expressed suicidal thoughts in their previous assessments." Which unfortunately means if we are going to target suicide prevention based on these predictions, people with suicidal thoughts will or will not go and engage in suicidal behavior, people with these factors. Unfortunately, that's kind of like shooting at a bullseye with our eyes blindfolded. The factors, the things that we have found in suicide risk prediction to be most important simply do not enhance our ability to predict suicide in an extremely meaningful way, in the sense of, is this patient who is going to leave my office going to kill themselves in the next month? Or is my colleague at work who's struggling with suicidal thoughts going to be alive tomorrow when I see them next? Unfortunately, none of our data helps us make those important decisions. And this is where public health interventions and going beyond suicide risk prediction and risk assessment is absolutely vital. And so why a public health approach when we often use psychological theories, which would be, again, sort of an intrapersonal psychological approach? Why move into the public health lens outside of the mental health lens to really prevent suicide? Now, I'll tell you, answering this question over the last 2 or 3 years for audiences has become much easier for me. And what I asked you to do is imagine our response to the COVID pandemic at this time without public health solutions. What that might have looked like is trying to get out of this pandemic with testing and treating infected people. That's the only thing we could have really done if it was all about assessment and treatment. Things like social distancing and our now vaccines are inherently public health approaches. We're trying to get ahead of the problem before someone is potentially infected. Right? We're trying to prevent the spread, not just get really good at identifying who's already sick. We had to go and get ahead of that problem for there to be a true solution to that. Unfortunately, what suicide prevention often does is it stays in this realm. And so I want to speak to what are the social distancing and the vaccines, the public health interventions of suicide prevention, in case you're not familiar. And I'm going to actually start with my work with the Walter Reed Army Institute for Research, working with active duty Army soldiers. In 2021, I actually saw the highest rate of active duty soldiers, people all enlisted and active duty Army killing themselves in 2021. It's actually one of the first times in history that folks who are active duty suicide seem to be killing themselves more than civilians. usually we see sort of a healthier, we call the healthier cohort effect, but especially during wartime, people who are enlisted in the military actually seem to be protected from suicide, but that has flipped in the post 9/11 war era. And what you will look at are these strategies that kind of mirror that of the civilian population. Outreach, don't be alone. Tell somebody that if you're struggling with suicidal thoughts, go get help. Focusing on the individual. Hey, go get a COVID test if you think you're sick. All right. It's kind of that idea. Really focusing on the individual person to identify their risk or identify risk in others and then go get help. Of course, intuitively that makes sense, but we've been doing this for a long time and it just simply doesn't seem to be making a big impact. Where my colleagues and I are starting to identify is something like the way military leaders lead their units may actually prevent the suicides of the subordinates or the junior enlisted people in their units. It's not simply about telling somebody to go get help. Maybe it's the way we even train leaders could help prevent suicides of those that they are leading. And what we are working on is this idea of leader-provided purpose, or in the way in which military leaders, particularly Army leaders, can help an individual that they are leading feel as though their military service has purpose and value. The day-to-day difficult things are meaningful, because if we can help them do that, then maybe they will have a more broader sense of purpose and meaning in their life, and thus suicide will be less of an option. And so I'll give you just a little bit of research on a study published, I think about a year ago now, where my team and I followed over 2,000 soldiers in a combat team deployment. And they were given surveys about their suicidal thoughts and how they feel about their leaders. They did that about 5 to 6 months into a 1-year deployment. So they were deployed overseas. And then they did that again 1 month post-deployment after the deployment was over, and then 3 months again. And so what we found is, even when we controlled for the changes in suicidal thoughts, because actually one of the better predictors of future suicidal thinking is past suicidal thinking. So we have to keep that in mind in our models. When we pull out that effect and we looked at what else sort of predicted suicidal thoughts down the stream, this is what we found. That leader-provided purpose, the more a subordinate or someone who's junior enlisted felt as though their leader was able to provide day-to-day sort of purpose and meaning to their deployment, we saw a 1 point decrease in suicidal ideation at a later time point. And a 1 point decrease isn't big, but I believe that total scale was like 12 points. So a 1 point difference is, actually pretty meaningful when it's not 100 points. It was a smaller scale. It's actually pretty meaningful. But again, this isn't about, treating somebody's mental health problems, or if you're struggling with suicidal thoughts, go get help. This is maybe the way leadership is involved can actually, we would call, trickle down to the suicidality of a subordinate. Other things that my lab and certainly, much smarter people than myself are working on in our country is access to lethal means. And the one I'm going to speak to the most here, and certainly we need to have an understanding of when we're talking about suicide, is firearms. So firearms attribute, in a given year, anywhere between 50 and 52% of suicides involve a firearm. In fact, suicides lead to death in 85 to 95% of suicide attempts in which a firearm is used, whereas all other methods, death by suicide, is the result in only maybe 5 to 10% of attempts at most. So it's the most lethal method for suicide, and it accounts for the most suicides in our country in a given year. So things like firearm safety strategies, promoting gun locks, providing cable locks to more securely store firearms is certainly one of the ways of getting ahead of the suicide problem. It's not about identifying who has suicidal thoughts, who's going to kill themselves. It's about making it harder in case somebody ever gets to that point. And so I'll show you, I think this is particularly important. If the national average at 51% of suicides are a firearm is involved in the US, in Louisiana, that's about 67%. We have one of the higher percentages of suicides by firearm in the country. And so this is certainly something in our community when we're thinking about suicide prevention needs to be at the forefront of our discussions. My colleague, Michael Anestis, now the executive director of the National New Jersey Gun Violence Research Center, formerly a professor at University of Southern Mississippi, has done some really great work at looking at how simple changes or to state laws regulating handguns may be related to state suicide rates. So what I'm going to show you is suicide rate by state, rate of firearm suicides, and percent of suicide deaths caused by firearm as it relates to whether or not a state over a given time point requires a permit to purchase a handgun or not. That's what the X is. And so let's take a look at this. In their data, they found a lower suicide rate in states that required a permit to purchase, a half the firearm suicide rate, and less percentage of suicides due to firearms. And this was controlling for poverty and population density rates, some of the things that you normally do in public health work. And so when we look at firearm suicide, it is not just about getting firearms out of the hands of people or creating these legislations. It's not always about restriction. It's thinking about how things like gun shop owners may play a role in suicide prevention, whether that's giving out information as people purchase firearms, holding regular workshops to discuss suicide with firearm owners. Similarly, how we may want to encourage suicide prevention and things like hunter safety courses. This is not necessarily about getting firearms out of somebody's home, but educating, coming to the reality of when a firearm is in someone's home, those inside that home are at a higher risk for suicide simply by it being there. Are they more likely to think about suicide? No, not necessarily, but it does make it more possible when that occurs. And the last one I want to speak to is actually even something like a change in the minimum wage of a state could be related to suicide. And what we found, not my lab, but a colleague found in an analysis of state minimum wage laws is that for about every $1 increase in a state's minimum wage, they see about a 2% decrease in suicides in that given state. And so something like state minimum wage laws, again, isn't going to fix everything, but it seems to be a small piece of that puzzle that, again, doesn't necessarily have to be about mental health and mental health treatment. So my take-home message for you is simple. Suicide prediction is really hard, if not impossible. Focusing specifically on increasing access to mental health care will help, but is not a panacea. It's not the answer to these problems completely. Suicide is a public health concern. Awareness, changes in things like firearm laws and minimum wage, finding ways to help people have purpose and meaning in their life day to day are all ways that we can help. And we all have a place where we wore masks and we physically distance. Similarly, in suicide prevention, we all play a potential role in that way. If I can be of any more help, or you have any more interest in the topic, please take a look at my website, and I'd be excited to share more information with you.
Well, my name is Rachel Bellany. I am a suicide prevention specialist with the Family Tree and Jacob Crouch Suicide Prevention Services, and we are located in Lafayette, Louisiana. Some of the services that the Family Tree provides, we have a Healthy Start program, which is a free program for women who are pregnant or parents that have children from 0 to 18 months old. And they receive support and all kinds of beneficial services to help them in their role as parents. We have counseling services, so we do offer counseling on a sliding scale fee. There's a $40 minimum, and we do accept some insurances, including Medicaid. We have a TICE program, which is the 2-lane infant and early childhood mental health consultation support and services. So they go into daycares and early Head Starts and provide support for those teachers and staff. We also have education classes. So these are for parents as well, and court mandated classes. So A Better Choice, Anger Choices. So those are anger management, domestic violence classes. We have Best Moms and Best Dads, and a transparenting class, which is for couples who have divorced, and so how to cope with that and manage that new dynamic. And for us, so Jacob Crouch Suicide Prevention Services is another branch of the family tree. And we have 4 team members with us. So we have Brittany Williams Wright. She is our suicide prevention coordinator. She serves Region 4 and she does the youth to about age 25. And then Mallory picks it up. So we have Mallory Goff. She's a suicide prevention specialist with us and she services Region 4 and she does the 25 and up range. And like I said, my name is Rachel and I provide statewide suicide prevention support and training through virtual, so through Zoom. And we also have Shannon Perez, who is our new part-time resource developer. And a little bit more about our services with Jacob Crouch. You can see here, this is a picture of Jacob Crouch. So he died by suicide in 2005, 3 days before he was set to graduate from the University of Louisiana at Lafayette. And following his death, his family and friends really wanted him to be remembered and for his legacy to not just die with him, right? And so they founded this organization where their main goal was to provide awareness and education about suicide to students in the Acadiana area. And so that's been since 2006. And they were going strong with that. And in 2010, we were able to expand our services to reach all of Region 4. And again, since then, recently, in 2022, we grew even larger. So it went from a one-man team to a 4-person team now, which is amazing. So now we're providing it statewide and we have all this extra manpower to really get our training and our support out there wherever it's needed. So some of the things that we offer right now, mainly right now we're doing QPR, gatekeeper training, which QPR stands for question, persuade, refer. It's an evidence-based training and it can be tailored to any specific group. So it could be law enforcement, healthcare, any population that we're bringing this training to, we can specialize it to meet their needs, right? We also provide it to students, so middle school and high school, college, all of that. And we also recently were trained to provide ASSIST, which is another evidence-based suicide prevention training. It's by Living Works, which is out of Canada. And so we are not currently offering that right now, but it is in the works. So that is definitely coming up. If anybody has interest in that, definitely let us know so we can start really working to get that scheduled. And we have a Survivors of Suicide Loss support group. And that's in person in Lafayette. And I'll go into detail about that later. And there is a online Survivors of Suicide support forum on Facebook too. So a little bit more about QPR. It's generally a 2-hour presentation or training, or if it's to students, we can make it 50 minutes to fit within that class period. And participants receive a 2-year certificate plus a lot of resources. And again, it can be virtual or in person. And if it's outside of Region 4, that's going to be virtual. But if it's within Region 4, then it could be either or, right? And it's free. And then a little bit about our support group. So we did do some restructuring to it recently. We decided to break it down into a closed group and an open group. So what that means is now we're offering a closed group, and that's going to be for a set period of time. It's going to be 12 weeks. So it'll start, you know, in this month on this day and end at this point. And that's just so everybody is kind of on the same page. They're all in that same process together. And because we've developed a curriculum so that it's not, you know, becoming repetitive and things like that. So we did decide to do that. Those meet bi-monthly, so 2 times a month in Lafayette. And you do have to go through an intake with a counselor on our counseling side with the family tree. And then we also are offering the open group. So this is going to be for people who have maybe already gone through the closed group, or maybe they've been in a different support group and maybe don't need that that specific curriculum, but just want to be around people who have shared a similar loss. And again, also the online support group on Facebook. And then a little bit more about the ASSIST workshop. So that is the Applied Suicide Intervention Skills Training by LivingWorks. It's a 2-day training, so it's a lot, but it's really, really good, really fun. I say fun, but you know, it's work, but it's a really good training. We're really excited to be able to offer that in our community now. So you learn how to prevent suicide by recognizing the signs, providing a skilled intervention, and developing a safety plan to keep someone alive. And again, that availability and funding is to be determined still, still figuring that out. But again, if you have interest, please let us know so that we know that there is interest and that we need to start getting it together on that. But, oh, and that's all I have.
All right. Hi, everyone, and good morning. I want to thank you so much again for joining our presentation, reaching out and speaking out. This presentation would not have been made possible without our wonderful partner, Acadiana Area Human Services District, and their Executive Director, Brad Farmer. We want to thank them again for partnering with us on this important presentation. We know that suicide is a topic that we all need to talk about, no matter how difficult sometimes it can be to talk about suicide. I first want to ask a question for Brad. Brad, what are some services that Acadiana Area Human Services has to offer?
Hey, thank you. And again, good morning, everybody. Thank you for being here. We're proud to partner and sponsor this. Acadiana area operates 5 full-time behavioral health clinics within our 7 parish area, Lafayette, Crowley, New Iberia, Ville Platte, and Opelousas. Outpatient, we're internationally accredited for outpatient behavioral health care. Adult, child, and adolescent have medical staff available as well, do intensive outpatient services. Also internationally accredited for crisis intervention, whether that's someone just walking in or whether it's, you know, somebody who's currently on our caseload that we're seeing who's in some sort of crisis. We have medical staff that is available to conduct PECs as needed. That's not always, I mean, that's not an immediate choice, but sometimes that is the most appropriate thing. We also partner with other community-based organizations like the Family Tree with the Suicide Prevention Program. We have a lot of prevention services, outreach in our communities and schools. For example, if someone was to come in and in some sort of crisis and needed to be hospitalized or even put, you know, in a residential facility or place, not put, but referred to a residential facility or detox, we have contract services available for that. So we do accept insurance, private pay, self-pay, Medicaid, but for the truly indigent population that has absolutely no means of payment financing, those folks are not turned away either. That is part of our charge and our mission. And so no one is denied services. We will see anybody that comes in, whether we are able to provide the service, maybe let a community partner see that, or just make a referral as appropriate.
Okay, great. So let's say someone is in need of mental health services. how do they contact Acadiana Area Human Services? What's the first step they should do?
Yeah, well, you could look online if you needed to. Our main clinic number here in Lafayette is 337-262-4100. They would speak with an intake worker and find out what's going on, take just basic information. We have changed our system a couple of years ago to do telephone screenings. Those can be conducted at that time of an initial call, very next day, or maybe even that afternoon. Telephone screening takes maybe 10 or 15 minutes. It's not a mini assessment. It is a screening to determine the appropriateness for someone coming in. We do not need a formal referral from primary care provider or a mental health professional. Someone coming out of the hospital, we try and get those folks in a little ahead of the average bear, if you will. We also follow federal block grant requirements for priority populations of persons coming in. And so we do that, but anybody can walk in at any time of our clinics and be seen, particularly for that crisis type situation. That is our priority of seeing those folks as they need to be seen.
That's great. It's so important to know that these resources are available. And again, just to further emphasize that people aren't alone. They just need to reach out and seek the help that is available.
Right.
Speaking of reaching out, Sherrod, now that 988 has replaced, well, not replaced, but has kind of become the new suicide prevention lifeline, have y'all seen any numbers go up in people calling the lifeline?
We have been seeing a pretty significant increase statewide with people calling the lifeline, especially with that initial launch in July. I mean, it was like a 30 to 50% increase. And that has we've stayed pretty much with an increase, but it's been great because it's been for a variety of degrees of suicide ideation. And we have been able to keep the numbers in which any form of involuntary dispatch of emergency services has stayed under 1% of calls, which is above national standards. So Louisiana is really doing a great job with their 988 implementation.
That's awesome. And speaking of different services that we have, Rachel, I know the Family Tree offers these great trainings. Can you tell us a little bit more about the difference between QPR and Assist?
Hey, yeah, so QPR is going.
Rachel, I'm afraid we cannot hear you.
Oh, no.
Oh, there you go. Now we can.
Okay, yeah, I was too quick. Yes, so QPR is going to be a 2-hour presentation. So it's super condensed, but full of essentially kind of the same information, that intervention piece and how to get someone help, how to see the signs. Assist is going to be 2 days, so it's a lot more intensive, and it's through a different program. So Assist is through LivingWorks, QPR is through the QPR Institute, but it's also an intervention skills training, and it really just kind of it dives a lot deeper into it and uses different types of models and things, but both really, really good. They're both evidence-based trainings, and you learn a lot from both of them.
And how does someone sign up to participate in these? Where can they go?
So for QPR,
Rachel, we can't hear you again.
okay, can you hear me now? Can you hear me?
Yeah,
Okay.
we can.
Okay, sorry about that. So for any of our trainings, you can reach out to myself or any of my team members. So Brittany, Mallory, or Shannon, and we can get that training scheduled for you. So QPR is kind of like on an as needed basis. So organizations reach out to us and then we schedule that with them. Whereas Assist, we can do that as well. However, it's because it's a 2-day and we need the facility, some sort of facility to provide the training. I think that's going to be a little bit different in how we go about scheduling that. And hopefully in the future, we plan to dedicate some days to offer it to the community. So people who are interested can, if they can make those those 2 days, then they would be able to attend.
Hey, Tatiana, I want to add on to that if you don't mind. I think this is true for Family Tree. I'm not sure. So Rachel, please correct me, but I know for us in a very similar line, we also offer mental health first aid trainings to the community on an ongoing basis. And I think Family Tree does that too. And so that's an excellent course for just community members, law enforcement, anybody that's interested. It's not specific to suicide, but it can certainly be related to that. We had tried to offer that on a quarterly basis prior to COVID and have just not picked up that schedule yet just because of everything going on with that. But we hope to do that very soon as well. And I'm not, again, I don't want to speak for Family Tree, but I think they offered community courses in that also. So that's a good resource for folks listening as well, as mental health first aid trainings.
Great, thank you, Brad. There's so many resources available that we just sometimes don't know exist. So I appreciate you for bringing up mental health first aid. I'm an instructor, so I know how important the course is for that. Brad, we have another question for you. Is there any specific trends in regards to mental health concerns that you're seeing specific in your region?
I don't think we are unique, we being our 7 parishes. I don't think we're unique from anything going on in the state or national right now. Mentioning COVID, I know there has been an uptick in some of our child and adolescent services with just folks transitioning back to school. Some of that's not so much related to COVID, but it's just that overall connectedness and attachment. And unfortunately, back in the news now that schools are in session, there seems to be, a lot of school-based violence and things like that. And so anytime there's those national events, and I know I've talked to, folks at Family Tree as well, and other community partners, that they see those things as well. I don't know of anything specific in Acadiana right now. Obviously, the opioid and fentanyl is all over the news. And again, I think that's true for Louisiana as a whole, but particularly in this area. So we're seeing a lot of those issues and concerns. Suicide is always, like I said earlier, unfortunately, one of our, key indicators and crises that we're looking at as well. But I don't think there's anything unique to us that's you're not seeing everywhere else.
Yes, thank you. And Sharon, I know that ViaLink has some services for youth. Isn't there different crisis text lines separate from 988 that youth can use who are in crisis?
Yes, we do have a crisis teen text line available that is available statewide and is free to use. The number is 833 text teen, which numerically is 833. I'm looking at my wristband that has the number on it. 833-898-8336. Again, 24 hours a day. You go directly to a live person. It's never automated. And that's available statewide for teens in Louisiana.
Thank you, Sharon. I knew that one was a good one to highlight, especially knowing our youth we're seeing really concerning rates of suicide in the youth population, and it is the second leading cause of death. So it's always important to highlight that there is a specific text line just made for youth. I wanted to ask, because I don't think we addressed it, but what are some signs that we should, and this is open to anyone, but what are some signs that we should look out for if maybe our loved one is experiencing thoughts of suicide? Is there anything in specific that we should be looking out for?
I can start. Can you guys hear me?
Rachel, I think if you lean forward, we can hear you better. I think that's what it is.
Can you hear me?
Yes. Mm-hmm.
Okay. So things to look for with a family member, maybe just anybody that you're close with. The biggest thing, and I say this in my trainings, is it's going to be any kind of changes in behavior. So I don't like to say that someone that with thoughts of suicide is going to look a certain way or act a certain way. It can really look like a lot of things, but typically it's going to be some sort of behavioral changes within that person that, because you're close to them, you'll be able to be aware of and identify. And I'd also just say, just trust your gut. If something is telling you something doesn't seem right, just trust yourself and don't be afraid to ask the person if they're thinking about suicide.
Mhm. Yes. Anyone else have anything else to offer for that question?
I just completely agree with everything Rachel said, that we don't want to limit ourselves and our scope or perception of suicide to any sort of particular universal warning signs or anything of that nature. And trusting your gut, you took the words out of my mouth, Rachel. I mean, you know your loved ones better than anyone, and it cannot do any harm to ask someone about suicide, or just make suicide and mental health part of your family dialogue and conversation, so that it doesn't have to be this big dramatic moment, that somebody just feels comfortable coming forward and being like, I'm really struggling today, and we can talk about it.
And I think one of the biggest myths that people think is that when you ask someone if they're having thoughts of suicide, that that's going to lead to suicidal ideation. And it's actually quite the opposite. It'll make them open up more and feel like they're finally being heard. So I know that's a big myth that kind of circulates throughout. Someone said they can hear you, Rachel. So I think that's good that you're being heard and your important information is going out there. So that's, like I said, that's one of the biggest myths, is kind of talking about suicide is going to lead people to think about suicide. And again, that's why we don't reach out or seek help, because we're afraid of what people are going to think or the stigma around mental health. I want to kind of dive into 988 a little more, because I think there is some misconceptions in regards to 988. Someone asked if I were to dial 988, would I automatically be enrolled in a behavioral health service?
So no, 988 is really that like emotional support or immediate like crisis intervention type of telephone service, where we're really trying to help somebody calm down, like feel heard, be de-escalated, feel a sense of control, a sense of their own safety. We do have resource referrals to behavioral health resources within the state, and we can absolutely help you get connected to a resource if that is what you want or what you need, but it wouldn't be any sort of automatic entree into any sort of behavioral health, mental health support. It would really be just that resource referral piece. So 988 is there when you need somebody anytime, day or night. It is possible to get resource referrals, but it's not an automatic entrance into any sort of mental health care.
Okay, great. And I know you mentioned in your presentation that most of the time the calls, y'all are able to de-escalate them via phone call before even having to dispatch services, which I think really speaks some truth about just the importance of just being heard and the need for a voice to be available when someone is in a crisis. We are wrapping up the conversation. I don't see any more Q&A from our audience. So I wanted to ask one final question for each of y'all. If there's one message that you want our audience today to get out, what would it be?
That's a very broad question. That's a tough one. I would say for the people you're working with, and just to reinforce the message that all the presenters said, and thank you all very much. You did fantastic. To let people know, reach out and talk to somebody. Call someone, call us, call Family Tree, call 988. There are a lot of resources available. This is a very serious topic. It's again, I just say unfortunate. I mean, that's a minimal way to say it, but it's a tragedy. And there are a lot of resources available. So if you're not familiar with those now, please find out what those are and share those with the people you work with and your family, your colleagues, your circle of influence. There are resources. So please, please, please call.
I'm gonna try. Can you hear me? Hello? Okay. So I would just want people to take some time today, maybe if it's 5 minutes, however long you can afford, to do something to take care of yourself, and to
maybe work on becoming more mindful of your own mental health, your physical health, emotional health, all of that. Just really take care of yourself, because that is, to me, the first step in, honestly, preventing suicide and coming together to help others as well.
And I would say just for everyone to remember that, suicide prevention is really a community effort and it's everybody's business. You don't have to have an advanced clinical degree or even work in the mental health field. It's really having the courage to break that stigma, talk about suicide like it is as normal and common as it is, not shame anybody for the way that their brain works, and have the courage to listen to people, really hear what they're going through. And just for everybody to know that your life is really important and there's always somebody that cares and that's there to listen. So please, please always reach out, always talk, and let's all just remember to be kind to each other and kind to ourselves.
Thank you, Sharon, for that important message. And what a way to conclude our presentation today. I want to thank Brad, Rachel, and Sharon again for being panelists today and joining us for live Q&A. Dr. Tucker is currently teaching at LSU, so he was unable to join us. I want to thank Brad again for partnering with the Louisiana Mental Health Association for this important conversation on suicide prevention. We will have the recording available later on, and that can be found through our website. I'll be sending a survey sometime today. If you could please take it, you'll be entered for a chance to win a ticket to our annual conference. Thank you all so much again for joining this important presentation. I hope you practice self-care and have a great rest of your Wednesday.
Thank you. Thanks, everybody.